to another international ACSD rounds. And it's my great pleasure to introduce Dr. Werner Budts, who is the director of the ACSD unit in Leuven in Belgium. And Werner has done a lot of work about physical activity in congenital heart disease patients, which is a hot topic. And I cannot think of anybody else better than him to teach us how to prescribe and how to advise our patients about physical activity. So Bernard, the floor is yours, and thank you very much for joining us today.
Okay, thank you very much for this very nice introduction, and also thank you for inviting me to give me the opportunity to talk about physical activity in patients with congenital heart disease, what they can do and what they cannot do. That's the most important question. So when we look to the learning objectives of this meeting, I think I would like to stress the importance of exercise in congenital heart disease, a short message about safety issues and sports, and then how to counsel for physical activity and recreational sports, and how to counsel for competitive sports. The thing is that we do know, and this is not only limited to adult congenital heart disease, but in general, physical activity is beneficial for patients. We do know that there is an improved exercise capacity if you have some training, if you have some physical activity. And it is not only the physical status of the patient that's going better, but it's also the mental health status that is improving when you do some physical activity or some sports. There is, of course, a lot of discussion how to define physical activity, and most of the people automatically think that this is performing physical training, following a training protocol. You could call it sporting. But on the other hand, physical activity also means that you are just physical active. That means that you walk, that you bicycle in the weekend, that you are doing some physical activities without this training aspect. On the other hand, we also clearly know that if you do not physical activities, or when you have a very sedentary lifestyle, that you might have a lot of adverse effects. And you know, the blood pressure is going up, it might influence your lipid levels in the blood, it might influence your body weight, and so on. So that means that in a certain number of patients, and also in ACHD patients, it might have adverse effects that you do not physical activities. Maybe this is partially due to the fact that patients with adult congenital heart disease are a little bit overprotected. It's the patient itself, or it were the parents, or it is maybe also the physician that tries to protect too much the patient with a congenital heart defect. So that's one of the explanations. And that's also the reason that the more that you are practicing in adult congenital heart disease, you feel that there is always a big uncertainty about the allowed physical activities. And I think the question for sporting physical activities, these questions will come up more and more, because the number of patients with adult congenital heart disease are continuously growing, as you know, and this is a very well-known slide from Helmut Baumgartner, where you can clearly see that the number of children with congenital heart disease is remaining the same, and these are data from Europe, but that the patients getting older than 16 or 18 years, that this number of patients is continuously growing, and that patients even getting older than 60 years, also that number of patients is continuously growing. So we have to deal with an aging population, and this might be important when we give some advice for physical activities. The reason is the following. The fact is that when you have an aging population, that means that our population starts to survive all the complications that are related to the congenital heart defects, and they are exposed to a new risk factor. And as I discussed already earlier, that means that this group of patients starts to suffer from high blood pressure, high cholesterol. They might develop diabetes, obesity, and so on. So you can clearly see with the increasing age that you have, of course, a higher cardiovascular risk factor. So that means that we are dealing with a new problem in patients with congenital heart disease, not specifically the congenital heart defect, but also the global cardiovascular risk. And this is just one example, and you will find more of them in the literature. But if you look to overweight and obesity, and if you look to patients with a double ventricular circulation or a single ventricle circulation, well, at least 20 to about 25% of our patients have too high body weight. So that means that even in a relatively young population, we are dealing with a risk factor, in this case obesity, and that is something that we do not want to see, because obesity again is related with high blood pressure, high lipid levels, and so on. On the other hand, are we already involved in this risk management? The answer is yes, but we are playing below par, which means, and I found this a very nice study, if you look to congenital heart disease patients with coronary artery disease, and if you look how many of them received antithrombotic treatment, it's acceptable, about 80%, that's fine. But if you focus on the lipid lowering therapy, you do see that these patients are only treated in 20% of the cases with the correct lipid lowering therapy. So that means that maybe we are aware, a little bit aware of the cardiovascular risk factors, we do not treat them as it has to be. And the same is true for the physical exercise. This is a study published already more than 10 years ago, but it still reflects what's ongoing in our patient population. You have the severity of the underlying congenital heart defect. The red line is indicating the minimum of physical activity that you need. And as you see for women and for men, most of them, they do not reach the goal of a minimal physical activity on daily basis. So and that's a problem. That means that we are not, let's say, sufficiently influencing our risk factors, our cardiovascular risk factors. So therefore, we have to consider congenital heart disease as really a chronic disease. And we have to initiate in a quite early stage this advanced care planning. And in the beginning, if we talk about advanced care planning, we are mainly focusing on the complications that are related to the underlying congenital heart defect. But now we have to focus more on the age-related comorbidities. And for example, physical activity is one of the variables that could influence these comorbidities to avoid the age-related death. This was a paper we published last year, where we think that this advanced care planning probably starts in the transitional phase from the moment when the patient goes from the pediatric to the adult care. So, but it's very important that it is not enough just to look at the risk factors related to the underlying disease, but also to the risk factors related to age. And we think in this case, we have to push people more to do some physical activities and to do some sports. Another problem is, but is it possible to do some physical activities and to do some sports? Is it safe? Because there it starts. The first thing that you test is whether it is safe to do some physical activities or sports. And also this very nice study, already a little bit older, 5 years old, but you can see that in patients with a simple congenital heart defect based on the anatomy, and patients with a moderate to complex congenital heart defect, that the exercise capacity between those who are doing no sports and those who are doing sports, that there is a significant difference. And this is not only true from the simple defects, but also for the moderate lesions and severe lesions. On the other hand, if you look to the, let's say, the mechanical data of this patient population, the ventricular function and the electrophysiological data of these two populations, there is no difference. But the patient seems to feel much better and function better. And in the same study, they looked at outcome and they looked at complications starting from 2001 to 2011, this cohort was followed. And if you see to the let's say the complications, arrhythmia, conduction disorders, and heart failures, the most common, there was no significant difference between the group who was doing sports and the group who was doing no sports. So this is, let's say, a first sign that indeed doing some physical activities might be safe for our patient population. On the other hand, and this is coming from a paper of Kojak from Amsterdam, where they looked at sudden death, and during exercise, they found that during exercise, sudden death only occurred in about 10% of the cases during exercise. So that means that exercise per se is not a real risk factor in these patients. So the thing is that based on the fact that we have to do something for our patients to get them more physical active, based on the fact that we think that there is a certain safety level, we want to give an advice. And we want to give an uniform advice about physical activities and recreational sports. And if you look around and if you talk with other colleagues, some people, they will say yes to a patient for a certain sport, and the other one will say no, and the other one doubts, and the other one say recreational is fine but no athletic. But the thing is, there is no exact uniformity, and that's the problem that we faced every day, that maybe someone from the same center was giving a different advice, and that's not good. It's confusing for the physicians, it's confusing for the referring physicians, it's confusing for the patients and his or her environment. And on the other hand, we have also the problem that we have to make a continuous balance. I don't know how it is in your practice, but we have a lot of patients with congenital heart disease who wants to test a little bit how far they can go, the fact of overboldness. So we have questions about skydiving, bungee jumping, what about triathlon, what about deep sea diving? So we have to make a balance, and also in that part, there are no clear guidelines available. And there are no clear guidelines how to make the balance between overprotection and the underprotection. When we started to think about making a kind of consensus statement, we looked at the guidelines that were at that moment available. And this is mainly focusing on the European part of the guidelines. And there were some recommendations for children related to physical activity and recreational sports, but we are not dealing with children, we are dealing with adult congenital heart disease patients. So there were also ESC recommendations about competitive sports and elite, recently updated. But again, these are recommendations for, in most of the cases, really very competitive subjects. So this could not be translated to our adult congenital heart disease population. And then there was a quite large consensus paper available where they focused on recreational sports, competitive sports, and elite, but this was specified by anatomy. And I will come back to this in one of the next slides. So we decided within ESC, within the working group of adult congenital heart disease, together with the section of sports cardiology, to think about new recommendations specifically for adults with congenital heart disease. So if we talk about specified by anatomy, what does it mean? And therefore we were a little bit confused because, for example, if you look to ASDs, well, if the ASD is closed, there are no restrictions. As an example, you could say, okay, that's fine for me. But for example, if you look to patients with the Eisenmenger syndrome, only low dynamic sports are recommended. And if we started to translate this table into the daily practice, we experienced a quite big problem. For example, an Eisenmenger patient is allowed to do some low dynamic sports, rock climbing. But this is strange because that's something that we do not want that our patient thus rock climbing as an Eisenmenger patient. And there was nobody talked about high dynamic sports like cycling, so that was a no. That's strange. What about ASD patients with pulmonary hypertension? There seems to be no restrictions. What about a fellow patient with a severe pulmonary regurgitation, normal right ventricular function? There is a no for high dynamic sports, for example, for badminton, but there is a yes for low to moderate dynamic and static sports, for example, running. So you do feel that there is something that we are missing. And this is also the reason I think that in that time period, we were giving some advices, but with a lot of difference at national level, international level, and even within a center, different advices were given. So that's the reason why we sat together and said, okay, let's go for a consensus paper. And we do know this is not based on, let's say, hard evidence, hard clinical evidence. So this is more level C of evidence, of course. The thing was that we wanted to make a kind of document which was clear, concise, and very practical, formulated in recommendations that can be used by congenital heart disease specialists or also by non-specialists who are following, in most of the cases, patients with mild disease. So, and what we thought that was, in our opinion, very important, that we could not get stuck with the anatomical diagnosis of the underlying defect. So it was important to implement the hemodynamic part and the electrophysiological part. And we think that those two extra elements, how the patient performs, independent from the underlying defect, that this determines the degree of the static component of the physical activity. And we skip the dynamic component of the physical activity and we replace this by the intensity of each type of physical activity. By the degree of the individual cardiovascular fitness, and I will come back to this in one of my next slides. So that means the static component of the exercise is important because this is strongly related to the pressure load of the myocardium, the left-sided myocardium, right-sided myocardium, and also the pressure load on the great vessels. And the dynamic component is then replaced by the intensity of the activity. We call it here the relative intensity. And the thing is, if you look to the, let's say, the physical performance, for example, for intensive playing golf, might be the same as bicycling in a moderate way. So, and the exercise performance for the two are the same, although you are doing some different sports. And that's what we wanted to achieve in this document. So we decided to make a 6-steps plan for physical activity and recreational sports. And it starts with the history, the anamnesis, and the physical examination. Then we assess 5 baseline parameters. We look to the type of exercise. We do an exercise test, preferentially a cardiopulmonary exercise test. And then we recommend the relative intensity. We do some follow-up and we have some feedback where it is necessary. So first of all, history, anamnesis, and physical examination. It's extremely important that when you give an advice to a patient with an underlying congenital heart defect, that you at least know the diagnosis and that you also know what happened with the patient and that you can predict a little bit on some predictive models that we have the late complications related to this underlying defect. On the other hand, you have to listen to the patient and you have to check whether there are some alarm symptoms. For example, syncope during an exercise is an alarm symptom. But for example, dyspnea is maybe not the reason why a patient cannot do some physical activities or some sports. You can imagine that, for example, an Eisenmenger patient will suffer from dyspnea. So symptoms do not per se exclude physical activity. And if you perform a physical examination, your physical examination has to align with the underlying defect. You have to look for the expected, and if there is something unexpected, you have to unravel why you find something unexpected. And that's your first step. The next step then is to assess the 5 baseline parameters. And we are looking to ventricular function, have in mind the pressure load, the pulmonary artery pressure, have in mind the pressure load, the aorta, the size of the aorta, have in mind the pressure, looking at the arrhythmias, and looking at the systemic saturation. And we hope with these 5 baseline parameters that we might have a certain idea about the hemodynamic and electrophysiological status of the patient. I'm not going into detail, but you can find in the paper a quite detailed table where you can see what does it mean ventricular dysfunction, what does it mean ventricular hypertrophy, ventricular pressure overload, pulmonary artery pressure, size of aortas. So we defined cutoffs, but again, we have to admit this is based on consensus. So this is not hardly proven with some scientific research. But by making these, or by evaluating these 5 variables, we ended up with, let's say, 5 different columns. A column on the left side where you see that everything is fine, and a column on the right side where you see that there are big problems with the ventricle, big problems with the pulmonary artery pressures, big problems with arrhythmia. But this is the first step within the algorithm. And then we go for the type of exercise. And as I told you, we only focus here on the static component of the exercise. So we are looking to the, let's say we are looking to the rows, but we are not looking to the columns. The columns are the older way of looking at an exercise. Looking at the dynamic component is, in this specific case, abolished. We only look at the static component. Because we do know from studies that the static component really is responsible for the pressure load of the great vessels and the pressure load of the myocardium. And you can clearly see, as probably most of you know, that there is less increase in oxygen consumption, that there is less increase in cardiac output. Heart rate is not that much going up compared to the dynamic exercise. Stroke volume is not going up. Higher pressures are achieved, and that the peripheral resistance is not going down during a high static exercise. So the thing is that that's the reason why we focus so much on the static part of the exercise. So this makes the algorithm a little bit more complete, and you see we have A, B, C, D, and E, where we go from up to high static. All static exercises are accepted, going to over moderate static to low static exercise. And you have to follow just this algorithm. And then you perform the exercise test. And peak oxygen consumption, we know that it's a parameter of physical fitness and outcome. You can determine maximal heart rate, which is quite important in this patient population, because it is possible that they take some medications that lower the heart rate. You can determine the Borg scale, as summarized here. It helps you to give you an idea about the transcutaneous oxygen saturation, and in case of desaturation, you have to re-enter the algorithm and see whether it is not necessary to improve this, for example, by coiling a collateral in a Fontan patient. You have to look at the fact whether there are rhythm or conduction disorders. And if you induce something, again, you have to re-enter the algorithm. You have first to treat and see what happens. Just keep in mind, when arrhythmia during exercise occur, that your risk of sudden death is increased 6 to 7-fold. And also, especially for patients with the right ventricular outflow tract, with the left ventricular outflow tract obstruction, you might have rise in systolic blood pressure. Sufficient is when it is more than or equals 25 millimeters of mercury, but you can also experience a drop in blood pressure, which is of course not a good sign, and maybe will ask for more detailed investigation. So we determine this relative intensity, and again it will be a mix between oxygen consumption, heart rate and Borg scale. If you have not the data available about oxygen consumption, you can base on or fall back on the heart rate and the Borg scale to define low, moderate and high intensity. And again, why this relative intensity? Well, the patient is its own control. You can never expect from a Eisenmenger patient where you achieve only 40% of the peak oxygen consumption that this one will reach suddenly 80. So you have to look into each specific, and this is then again related to the anatomical part of the defect. You have always to look at each patient itself to see what is the relative intensity that you can determine. And then it makes the whole algorithm complete. So that means if you have patients, for example, here in the left column, if there is no problem with the ventricles, if there is no problem with pressures, is there no problem with sizes, saturations, and the electrophysiological stages, you can stay here. You can go up to high static exercises, and you can do this at high intensity, defined in this algorithm as a Borg scale between 15 and 17, and a training heart rate going from 75 to 90%. On the opposite, if you are here in this red zone, the fifth column, yeah, you are still allowed to do some low static exercise, but at low intensity. And I think this is important to keep these patients active, physically active, not doing following some training protocols, but just try to walk, try to bicycle if it is still possible. And the thing is, of course, if you end up, as an example, in the second column, it is indicated that it is better to go to up to moderate static exercise, and that you can do, in case of moderate static exercise, you can do this at high intensity. If for some reason, and it's always a discussion with the patient, if for some reason this patient really wants to do up to high static exercise, we suggest then to do it at a moderate intensity, so that we correct a little bit. When they go too high static, we do it at a more lower intensity level. And so that was the whole idea behind this algorithm. So some extra remarks. The fifth step is then the relative intensity, and we think that you have to do at least 3 to 4.5 hours per week physical activities or sports if you would like to have a certain clinical benefit. And the minimum minutes per session should be 30 minutes. And of course, you have to perceive. It means that it's not because you have a training for 3 months that you will have the clinical benefit in 3 or 4 years. So you have to continue. The patient has to continue, which is also very important and also a very big problem. Many people, they start, but it is very difficult to keep them busy and to continue with their training process, or to keep them physically active. Some questions come up about team sports. Well, you can participate as a patient with congenital heart defect in teams with similar physical fitness. So the patient has to avoid that they are the weakest part of the chain when they do some team sports, because otherwise they will be always forced to go to a higher intensity level than was programmed for them. And I think this is a very important thing, not only for the patient's mind, but also for the patient's safety. Of course, when there are new symptoms arriving, this is step 6, yeah, you have to discontinue the physical activities, and you need to reassess. Physical activities with medium or low intensity, what about follow-up? Well, we suggest to follow the follow-up by the ESC Good guidelines, defined more than 10 years ago in the ESC guidelines, and the more recent ACHD guidelines published in the European Heart Journal in August, and coordinated by Helmut Baumgartner and Julie de Backer. Physical activities with regular high intensity. Well, if you go really to high intensity, it's better to look at the follow-up guidelines of the ESC as an example, because I'm talking as a European, of course, for competitive and elite sports. So a more frequent follow-up in this case. There are some specific cases also. What about permanent pacing or resynchronization therapy? You have to keep in mind it does not preclude physical activities, it does not preclude sports, and it does not preclude high intensity. But you need, of course, in a certain way for a certain, let's say, appropriate rate adaptation. This is quite obvious. And this is more an electrophysiological discussion, and I'm not an electrophysiologist, but it seems to be that a minute ventilation-based rate response system is preferred over an accelerometer-based system because it is more aligned with the physiological rate response that you need. Exercise testing and Holter ECG monitoring can help to program the pacemaker or the resynchronization therapy device. And you have to keep in mind, of course, that increasing chronometry is not always effective, for example, in restrictive ventricles. And that sometimes the heart rate is going up too much in a certain group of patients, which reflects in an impaired physical performance. What about implantable cardioverter defibrillator? There is a lot of discussion, but again, low to moderate intensity physical activity or sports are recommended. But it is, of course, unclear how effective cardiac defibrillation during a peak physical exercise will behave. Fatality seems to be rare. There are no reports of increased lead malfunctioning, and arrhythmias were more frequently detected during the physical activities, but again, not more sudden death, but more inappropriate shocks, of course, because of the higher heart rate. And if there is a kind of contact sport, yeah, you need to keep in mind that there might be a certain risk for damage of the device. But some people, they protect themselves with a specific shield that the device that they are wearing is not damaged by a direct contact. So to come back to the examples that I gave, an Eisenmenger patient, you remember the strange example that I gave you. When you put the Eisenmenger patient here in this algorithm, it's a patient with a central cyanosis. He can do some exercises up to moderate static because he's ending in this box, and finally this at low intensity. And we try to align all our advices based on this algorithm. Going back to the patients with the tetralogy of Fallot repairs, suppose that everything is fine, no dysfunction, nice pressures, aortic size okay, no arrhythmia, no desaturation. Well, this patient is allowed to go up to high static exercise at high intensity. Why not? So this makes it a little bit more practical, and we think that this could be, let's say, a good basis for our counseling duty to our patients. Of course, we wanted to validate this, and this is an abstract of a pilot project that we started a few years ago and was presented at the Belgian Society of Cardiology. It was coordinated by Rosalind Buys, our exercise physiologist. And here we looked at 40 patients with an underlying congenital heart defect with different kinds of anatomical severity. And we compared the patients with 20, let's say, other patients, but doing not this start to sport protocol. And what we found is that there were in 16 weeks monitoring, 3 months monitoring, sorry, there were no adverse events. In this group of patients, only 40 patients, but what you could see here is that in the intervention group, the peak oxygen consumption was significantly increasing, and further sub-analysis, which is not shown here, that also the quality of life scoring was improved by, let's say, coaching these patients over time. And you can see that to hope that these patients follow their training protocol, there was telecoaching continuously. It was a very nice program where these exercise physiologists contacted every 2 or 3 days per week the patients, and when they get stuck in their training protocol, she sent them some YouTube films where some specific exercises were explained. And now people, we want to restart this program, but now people are still asking when does it restart, because I feel better. And the feeling better is not only the physical part, but it's also the mental part. But the problem is that not all of our patients are not only restricted to recreational sports and just physical activities. We have another part, and that's patients who want to do some competitive sports and athletic sports. So this was still a gap in our position paper or in our consensus statement. But in competitive sports and athletic sports, there is a difference with the previous algorithm. So athletes will push themselves to their limits. So they will always go to maximum intensity. And as such, the notion of relative intensity-based exercise prescription is not practical. And this is quite obvious, because they would like to go over the red line. That's typical for athletes and people who are really in competition. Again, this is level of evidence C, undoubtedly. The thing is that we try to base on the same algorithm that we previously discussed, but now in 5 steps. First of all, looking at history and physical examination, because you have to know the underlying congenital heart defect, and everything has to fit. That's important. Then you assess the 5 baseline parameters, the same as you have seen previously, to determine the electrical and hemodynamic stability of this patient population. And again, we made a lot of tables where you have really cut-off points when we consider a patient having a ventricular dysfunction, having a ventricular hypertrophy, ventricular pressure overload, and so on. It's a quite long table, so I couldn't fit this in one slide, but it is very interesting to go through. When we wrote the paper, there was a discussion about ventricular hypertrophy, because when patients start to do some competitive sports, and when they start to do athletic sports, there is also a physiological hypertrophy. So we had to correct a little bit the ventricular mass for this group of patients who wants to do the competitive sports and athletic sports. And then the next step is assessment during exercise, again, the cardiopulmonary exercise, to determine the physical fitness. And meanwhile, the view to physical exercise and sports was changed over the years, and there is a new kind of, let's say, description of the type of sports. Now we are talking about skill sports, power sports, mixed sports, and endurance sports. And if you look more into detail, the skill sports, they have not that much cardiac remodeling, so that is fine for a great number of our patients. A little bit more cardiac remodeling in power sports, mixed sports, more cardiac remodeling, and endurance, of course, a lot of cardiac remodeling. So we are not talking here about this, the static component, what we implemented in our previous algorithm. We are here not talking about the older algorithm of the, let's say, the combination static and dynamic. So now we are focusing more on this skill, power, mixed, and endurance sport. And you have just to look at the list, because here we are talking about competitive sports and athlete sports, not about recreational sports and physical activity. And then we end up here with a more simplified algorithm. When everything is here in the first column, you end up with A. And A means that you can do all sports and that you can go for maximal intensity. So you will not find here the relative intensity anymore. Here on the other side of the slide, you will see in the red wording, yeah, this is a level D or a class D, and there no competitive sport is allowed. And then you have something in between where only skill, power, and mixed sports are allowed, or only skill sports are allowed. But it does not mean if a patient cannot do some competitive sports, they can still enter the algorithm of recreational sports and physical activity. So it's a kind of continuum. There are some specific cases. The remarks about pacemaker and automatic defibrillator are similar to what we have discussed earlier. One notion about exercise at high altitude, when the patient is doing some sports above 1500 meters, well, we do not like that patients are doing competitive sports when they are cyanotic, unrepaired, or palliated, or when they have some pulmonary hypertension, when they want to do some sports at higher altitude above 150 meters. But it does not mean, again, that you can do not some recreational sports, or you cannot do some physical activities at higher altitudes. The reasons for that is that if you really go to a high intensity, that in these cases there is more arrhythmia detected at higher altitudes. And finally, but I think this is obvious, but I would like to make it complete because you will find it also in the publication, there is advice against contact sports when you take some anticoagulation. And I can imagine that in competitive sports, the contacts are more rough than in the recreational sports. I hope so. So this is the eye catcher of this document, where it is again important to look at these 5 variables, making the balance, electrophysiological status, hemodynamic status. We obtain data from rest, we obtain data from exercise, then we make, let's say, an evaluation depending on the athlete's wishes, how far he or she wants to go, and then we decide on the type of sport that will be recommended in a competitive way, or when they really go for an athletic sportive activity. So in conclusions, ladies and gentlemen, dear colleagues, and dear chairman, a minimum of physical activity in all congenital heart disease patients is required. I think this is a very important message. Think of advanced life care planning. So this is a number 1. General exercise protocol seems to be safe on the short and maybe also on the mid-term for patients with congenital heart disease. So be not afraid to advise to do some sportive activities. And these consensus documents that I showed you here might help to counsel for an individualized sport advice. And probably they need to be adapted when we tested them, when we did some randomized controlled trials, as we did with our small pilot trial. But as I told, the current algorithms might open the door for randomized controlled trials, because we are now at a level C evidence, expert opinion. But what does it mean, expert opinion? So we need to go to a level B and preferentially to a level A of evidence. And I hope once that we can set up a bigger trial with a lot of centers where we follow the same exercise protocol or the same training protocol, and then come to a clear answer on our remaining questions. Thank you very much for listening to me, and I give the word back to the moderator and chair of this session.
So thank you, Werner, for an excellent talk, very practical and I think very helpful. So the paper is open for discussions. If anybody has any questions, either you can write it in the chat or just unmute your microphones as ask questions. While people think about questions, I have a couple of questions. So you did the document, and it's been very helpful for all of us. How much of that do you do in your daily practice? So how many patients really do you advise in? Is everyone that you come through your clinic, you advise them about physical activity? Or how much really do you use this in your daily practice?
Well, I must say almost 100%. So when the patient comes to our hospital, they have a first contact with a nurse specialist. And the nurse specialist is trying to unravel the cardiovascular risk of our patient population. So they ask for smoking behavior, check body weight, they check blood pressure and so on. But they also specifically ask, what type of sports are you doing? What type of physical activity? How many hours and how many days? And when it does not fit with the protocol that we have seen, for example, for recreational sports and physical activities, we will advise to align as good as possible with this. So it's for us, it's something that we try to implement in daily practice. The only problem is that you can give the advice, they start, but they need to continue, and that's the biggest problem. And we need to find a way that we can continue to coach the patient and to keep the patient motivated to continue with the protocol or with the advice that we gave. So that's the reason why we extended the algorithm with the telecoaching in the pilot trial we performed. And this algorithm was also used in a big European project. It was the Pathway project, where this protocol was implemented in a software system, and a software system that was coaching patients at home. About 90% of these patients were patients with coronary artery disease and valvular disease, and about 5 to 10% of these patients were patients with congenital heart disease. And again, there we could show that they improve their physical performance, that they feel better, but the problem is you need something that they continue doing this. And continue doing sports is maybe sometimes more difficult than continue to take a medication. So that's very, because you can show this algorithm and discuss this algorithm, but if they not continue to follow the advice, probably we will have no effect on the clinical outcome, and that's something that we need to realize.
So there is a question in the chat that thank you for the very clear answer, and there's a question in the chat about what is your advice about isometric exercise?
Well, we would again, when a patient is submitted to a pressure load, that means right ventricular outflow tract obstruction, residual coarctation, arterial hypertension, and so on. We think that isometric exercise is pushing too hard on the myocardial muscle and on the vessels, on the wall of the great vessels, and we would then go to prefer to a low static exercise and not to a high static. So we are not against, but especially in those with a pressure load, we would like to avoid it as much as possible and go for dynamic exercise as main part of the physical exercise.
Mm-hmm.
I hope that's an answer on the question.
Yeah, so there is another question here. So, follow repair adult patient with residual RVOT grading over 35 millimeters of mercury, normal RV size and function. Regarding your experience and algorithm, are there any limitations for physical activity? So, followed with residual RVOT obstruction of 35 millimeters of mercury, normal RV function, normal RV size. What would be the advice?
Well, my advice, well, first, again, this is the anatomical diagnosis. We have always to follow the algorithm. We have the anatomical diagnosis. We put them on a bicycle, see how far he can or she can go. But if all the 5 variables are within the limits that are accepted, then we go for up to high static and up to high intensity exercise.
I think that what I get from your talk, and I think that is something that you've been saying for years, is that we need to move away from the anatomical diagnosis of the patients and assess the patient functionally, including what is the anatomical problem, what's the function, the size of the aorta, all the parameters you have set, and get the patient as a whole picture of the patient in order to decide whether or not you can exercise. Because you might have somebody with this patient, for example, might have VT, and that would be a completely different patient than the same patient without VT. So that's what I get from your talk, what I've been hearing from you for years. And I think that's a very intelligent approach. Erwin, I guess that you have. Sorry, Werner, go.
No, sorry. It's all. But again, therefore, this extra assessment is very important. If this patient has in the past arrhythmias with short episodes of ventricular tachycardia, it changes the device. It changes the advice completely. If you put them on a bicycle and there are some arrhythmias occurring, okay, then it completely changes, and you shift from this column A to another column, or you first have to treat the problem and then to reassess and see whether it still exists or not. Suppose that you can ablate ventricular tachycardia in that specific patient, and you don't find any arrhythmia anymore in your next assessment after the ablation, then you can go, in our opinion, relatively safely to a high intensity activity.
Erwin, I guess that you want to make a question?
Thank you very much, Werner, for your excellent talk. It's very practical and gives us very important guidance how to counsel patients who want to do recreational sports or even competitive sports. I'm a very practical man. So I'm simple. And when we counsel patients, or if I counsel patients in my clinic, the first question is always, what are your preferences? What type of sports you're doing? That's a very important question. Important question so that you can engage the patients in exercise activities. But usually what I use, I take it very simple. So it doesn't matter if the patient does isometric exercise or dynamic exercise. I say as long as you can talk during exercise, then you're fine. So that's a simple rule, a rule of thumb. It's very simple for the patients. So as long as you can talk during exercise, chat with your colleague, then you're fine. But if you cannot talk anymore, then you overexert yourself. Or if you do isometric exercise, you should be able to do 12 to 15 repetitions without straining or without the Valsalva. That's very important for patients, say orthopathies. So that's a very practical approach when I counsel my patients. Usually I don't go through the entire algorithm because in the clinic I don't have time. But if I have a patient who ask me about competitive sport. Okay, then you need a proper assessment, as you told us.
Yeah, but I completely agree. And if you look to the first algorithm with 5 columns, so column 2, 3, and 4, where we talk about this moderate intensity, is in complete alignment with what you just said. When you are doing some exercise and you can still talk to people around you, then you are probably in your moderate intensity part. So if I have, but meanwhile I know it by head now, this algorithm, but that's one thing, and I completely agree. This is very practical, and in most of the cases, if patients ask us to go for what kind of physical exercise do I have to do, we try to convince them to go to a dynamic exercise like walking, bicycling, doing things like that, because that is moderate to low static, has probably no real pressure load on the global circulation. And if you then apply what you just said about you can still talk when you are breathing, then I think you have given a very nice general advice to that patient. But if they come with more specific questions, like rock climbing and squash, and then you have to see, okay, this is a partially static, partially dynamic, then you have to make the balance. And then this algorithm could be useful to see, okay, if we would like to give a uniform advice, what advice am I going to give? And what advice would then, based on this algorithm, would my colleagues give to get a certain alignment? Because again, what we experienced about 5 to 10 years ago, and still no, it is still the case that in some centers people are not allowed to do some exercise, and they are surprised if they come for a second opinion to us that suddenly they can bicycle to their work, for example. So for them a new world is opening, and I think that's important. Again, this mental part, the physical part is also important, but the mental part here is also important, because then they say, yeah, but they've always told me not to exercise, and we are just saying the opposite. And sometimes they feel a lot better then.
I think.
Sorry, Argo.
Rafa.
No. So just to say that that's a very, very general advice and very good way of a shortcut, but encouraging everyone to follow the algorithm, because I think it's one of the best things that we have as a tool for our patients. So there is no more questions. Is there any other questions on the?
I just want to make a comment, just to emphasize the importance of exercise.
Yeah.
For all of us, and also for our patients. 5 or 6 years ago, I had a patient with impaired petralgia fallow, moderate to severe pulmonary regurgitation, and he also had a stroke actually after the initial repair of his tetralgia fallow on some residual neurological deficits. And he asked me, "Oh, can I climb Kilimanjaro? I want to climb the Kilimanjaro." Okay, I say, okay, so let's do the same. What you just recommended, an exercise test, a cardiopulmonary study. The oxygen consumption was about 70% predicted. And then he underwent regular exercise, went to the gym, and he came back 6 months later. His oxygen consumption was 99% predicted. Just this tells you how important regular exercise is. That when you do regular exercise, you recruit the skeletal muscles for the oxygen consumption. It's a chain from the lungs to the skeletal muscles. And actually, the patient managed to climb the Kilimanjaro. He did it. It was a great achievement and a very important achievement for him. Was very important for him.
And these advices are very important because, again, this is a patient who achieved something that he maybe thought never could have achieved. So, and that's important, and that's, yeah, maybe much more important than having one extra systole during an exercise test. You know, that this mental status is may not be denied as healthcare givers.
Okay, so I think it's 9:05, and I think we're gonna wrap up. There is one question here. I'm gonna ask the last question for Gordon. Just put it on the chat. If lower risk patient with low moderate intensity objectives, is there even really a need to medicalize physical activity with formal CPET? Would there be a benefit to incorporating or assessing intended physical activity when considering plan for assessment?
If I understand the question well, is if someone ends up in the low moderate?
In patient, so Gordon, you might want to unmute your microphone and you ask your question. He might not. So I understand that patients with low moderate intensity and patients with low risk, if there is a need to do a formal CPET and put part of their treatment to do some physical activity, and say whether it would be any benefit of incorporating physical activity in the plan of the treatment of the patient. That's what I understand with the question.
Yeah, what we had this discussion when we looked at the consensus paper. Of course, you can always make exceptions. It's just a suggestion. But I think if we follow our patients with congenital heart disease in general, from time to time we are doing some exercise tests. I know in some centers it's by each visit. We have not the capacity for all our patients for systematically doing cardiopulmonary exercise testing, but in most of our records we have an exercise test available that it is not necessary when a patient wants to start walking or commuting by bicycle, for example, that you immediately have to go to the cardiopulmonary exercise test. If your hemodynamic and electrophysiological status at that moment is stable and it is a low risk patient for, let's say, arrhythmia or conduction disorders, and you have a test available from the past, I think you have enough to give this advice. I completely agree. But if you go a little bit further, yeah, we prefer to do these exercise tests because sometimes you still find some conduction disorders, unexpected arrhythmia. It then depends also again on the underlying anatomical disease. It depends also on the anamnesis of the patient. Is a patient, for example, has a repaired atrial septal defect, has some palpitations from time to time, and then they want to do some regular exercise, but regular exercise. I think it's not a big deal to just put them on a bicycle and have at least a kind of reference where you can look at when you give an advice to the patients. So it's really, yeah, it's really individualized, of course. But again, in most of our patients, we have an exercise test available, but not every year, of course.
Okay, thank you very much. So he answered that perfect, and thank you for the answer. So thank you very much, Werner, for joining us today, and excellent talk, very practical, very helpful, and thank you for the work put on the talk. Thank you everyone for joining us as well. So we'll be here next week, actually discussing a topic that we have been touching upon today, which is going to be ablation in VT in Fallot. And hope that you can join us, and good morning, good afternoon, or good night, wherever you are in the world. Thank you, Werner. See you.
Thank you very much. It was really my pleasure. Okay, bye-bye.